Good afternoon, ladies and gentlemen, and thank you for waiting. Welcome to the Basics of Antibiotic Resistance, focus on Carbapenem-Resistant Enterobacteriaceae call. All lines have been placed on listen-only mode, and the floor will be open for your questions and comments following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Medora Whitwer. Ms. Whitwer, the floor is yours.
Thank you. Actually, this is Christy Wergane. I'm going to start out, and I'm with Stratus Health, the Minnesota organization that's part of the Lake Superior Quality Innovation Network, or LSQIN. The LSQIN represents Minnesota, Michigan, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. I would like to welcome you to this educational session. We're pleased to be collaborating with the Minnesota Department of Health to provide this webinar to you today. This topic is a great example of the National Nursing Home Quality Care Collaborative Strategy, provide exceptional, compassionate quality care that treats the whole person by striving to prevent problems and treating them when necessary. The link to the change package is on this slide, and please note that Appendix 4 of the change package is a change bundle that identifies strategies to prevent healthcare-acquired infections. So you might want to look at that for more resources on this topic. All lines will be muted during this webinar. After the presentation, we will have time for questions and answers, so please make a note of any questions that may come up, or feel free to write them in the chat. And we can, if necessary, we can address those questions as they come up. I will now turn it over to Medora Whitwer to introduce our speaker for this afternoon's session. Medora is an epidemiologist for the Infection Prevention and Control and Antimicrobial Resistance Unit at the Minnesota Department of Health. Welcome, Medora.
Thank you. So it is my honor to introduce Dr. Nimalie Stone as our speaker. Dr. Stone is a medical epidemiologist for long-term care in the Division of Healthcare Quality Promotion at the Centers for Disease Control and Prevention. She is a board-certified infectious disease physician who has a research and clinical background in managing infections and antibiotic-resistant pathogens in post-acute and long-term care settings. She completed her internal medicine residency at Johns Hopkins University, followed by an infectious disease fellowship at Emory University. Prior to joining CDC, she spent several years providing clinical care and advising infection prevention and control programs for a long-term acute care hospital and affiliated nursing home within the Emory healthcare system. In her role at the CDC, Dr. Stone works to address the needs for infection prevention programs in long-term care. She develops guidelines, educational resources, and quality improvement programs to reduce healthcare-associated infections and promote antibiotic stewardship in nursing homes. Her efforts include leading the SHEA CDC position paper, updating infection surveillance definitions for long-term care facilities, and overseeing the inclusion of infection surveillance infrastructure designed for use by nursing homes and assisted living facilities within the CDC's National Healthcare Safety Network. Dr. Stone serves as a technical expert for multiple AHRQ-funded projects promoting infection prevention and antibiotic stewardship in long-term care, and works closely with CMS divisions focused on quality improvement and infection prevention oversight in nursing homes. She is nationally recognized for her teaching on infection prevention and antibiotic stewardship in long-term care, and serves as an infection prevention resource for state health departments and national quality improvement initiatives such as the Advancing Excellence in America's Nursing Home campaign. Thank you, Dr. Stone. I'll hand it over to you.
Afternoon with our colleagues about antibiotic resistance, and thanks also to Stratus for their support of this webinar. In the next 40 minutes or so, I'd like to talk about the common bacteria that cause infections in nursing homes and the antibiotics that we use to treat them, and the role that antibiotic resistance plays in challenging our ability to treat these infections. And in particular, we're going to focus on carbapenem-resistance and go into a little bit of detail about carbapenem-resistance in the family of gram-negative bacteria called Enterobacteriaceae. And then if we have some time, we'll talk about ways that your laboratories can be partners in helping provide information about antibiotic resistance in your facilities. So it's a lot to cover and somewhat complex concepts. So please do send your questions as we go along, and I'd happily stop and try to address any questions you have, so everyone is comfortable with the information. For many of you, this is probably review, but being an infectious disease doc, I like to talk about the bugs a little bit and remind ourselves about the common bacteria that we encounter in healthcare. What you're looking at are two types of bacteria stained with the gram stain. On the left of the slide, the purple colored organisms are called gram stain positive because the bacteria take up a crystal violet stain, which gives it that purple color. On the other side, you see sort of a pink or red looking group of organisms. Those are considered gram stain negative. And the features of how bacteria grow and how they look under the microscope and even how quickly they grow are all characteristics that we use in the lab to help us identify them. And often we use these same kinds of growth characteristics to develop the antibiotics we use to treat them. So when we think about gram-positive bacteria, a lot of the organisms that we see in healthcare settings, which are gram-positive in staining, are the gram-positive cocci, or the round-shaped bacteria. And there's an image of gram-positive cocci at the top of the slide, likely heard of or seen and treated in your residence are streptococci, staphylococci, and enterococci, all of which are gram-positive round bacteria or gram-positive cocci. One of the common gram-positive rods that we encounter is Clostridium difficile. It's an anaerobic bacteria, meaning that it doesn't like to grow in the presence of oxygen. The gram-negative bacteria that we frequently encounter in healthcare are rod-shaped or bacilli, and you see an image of those to the right at the bottom of the slide. And the common organisms that fall into the gram-negative rods are E. coli, Klebsiella, Proteus, Pseudomonas. Some of those bugs are frequently culprits in causing urinary tract infections, for example. Looking a little bit more closely at these gram-negative bacteria, we can categorize them into families. And the big family that we're going to focus on are the Enterobacteriaceae. That is a fancy Latin word for describing the bacteria that grow in our intestines. Entero means is the word for GI tract, and Bacteriaceae is bacteria. So this is just the bugs that grow in our lower intestine and in our intestines. And the common types of bacteria that fall into the Enterobacteriaceae family include E. coli, Klebsiella, and Enterobacter. And you can see in this table some of the common culture sites where we might encounter these bugs. Now, there are some other important gram-negative bacteria not to be forgetful of, and those include Pseudomonas and Acinetobacter. They also have a pretty strong role when it comes to antibiotic resistance, so I want to make sure we think about them and mention them, but they don't get classified into the family Enterobacteriaceae. That's the difference. So switching gears for a moment away from the bugs to just take a quick review of the common antibiotics that we use to treat these infections, because it's the combination of the bacteria and the drugs that are at play when we think about resistance. So as you all know, antibiotics are a group of drugs that we use to treat and kill bacteria. They're grouped into different classes based on their structure, and I like to think about the spectrum of their activity. So narrow spectrum antibiotics are drugs that really target very specific bacteria, while broad spectrum agents can kill across a diversity of organisms. And I'll show you some examples in the next few slides of narrow spectrum versus broad spectrum. Now, the problem with antibiotic resistance is that now our bacteria are no longer fully killed by the drugs. And we know that bacteria with resistance cause patients to have more severe infections, and they're often more difficult and more costly to treat. And when we think about antibiotic resistance in terms of our infection prevention program, we often look at keeping track of certain bug-drug combinations for resistance, and we'll look at some of those in a moment. But again, I know this is probably review for many of you, but just to help orient all of us to the types of classes of antibiotics that are out there. The beta-lactams include the penicillins as well as the cephalosporins. And penicillins, there have been changes made over time to the basic structure of penicillin to extend the activity of some of these drugs. So methicillin specifically is active against staphylococcus. The extended spectrum agents like piperacillin and piperacillin get more broad coverage against both gram-positive and gram-negative organisms. And for several of these drugs, we can actually combine them with another agent to help them overcome some of the common bacterial resistance that can emerge. So a bacteria might be resistant to amoxicillin by itself, but when you add clavulanic acid or clavulanate and make augmentin, that molecule clavulanate allows the drug to now be active. So these are additives to some of these drugs to help them overcome resistance. Cephalosporins I think of as the cousins to penicillins, and there are several generations of cephalosporins. The first generation drugs tend to have more gram-positive activity, and examples of that are cephalexin and cefazolin. But when you get into the third and fourth generation cephalosporins like ceftriaxone and ceftazidime, you tend to have more gram-negative activity. And ceftazidime and cefepime in particular are known to be active against Pseudomonas, unlike ceftriaxone. So even within a class, you can see different spectrums of coverage. Moving from there to the carbapenems, these are among some of the broadest spectrum agents we have. They're powerful, powerful drugs. And as you can see by the number of different bugs that are affected and killed by carbapenems, when you think about spectrum, these are big gun, broad spectrum agents. Many of them are only available in IV formulation, and they tend to be more costly as well. Just to highlight briefly some of the other common agents that you will encounter and we use frequently in healthcare. On the gram-positive spectrum of drugs, we have things like vancomycin and daptomycin and linezolid. All of them are used to treat MRSA and often enterococci. Remember, with vancomycin, although there is an oral form of vancomycin, it is not absorbed from the GI tract into the blood or tissues, so it's only used to treat infections that happen locally in the intestine, like C. difficile. The IV form is the version that you need to treat infections like MRSA, and that's a very good levels in the bloodstream. Moving to some of our gram-negative agents, we have the fluoroquinolones, commonly used for urinary tract infections, and the aminoglycosides. And while the aminoglycosides are excellent drugs for gram-negative infections, we tend to be a little nervous about using them because they are known to have some serious toxicities if we don't monitor the levels of these agents in people, and in particular kidney toxicity as well as damage to the inner ear and vestibular nerve can happen with long exposure to the immunoglycosides. Here are some other miscellaneous antibiotics, again, pretty commonly used in the nursing home setting, like Lactam, which we see a lot for treatment of urinary tract infections, but we have to be sure to monitor people's kidney function because there can be impact on creatinine clearance with Lactam. Sometimes people think of it as a narrow-spectrum agent, but it actually has pretty broad activity against both gram-negative and gram-positive bacteria. A drug that we often see for respiratory infections is azithromycin, and then metronidazole, which is primarily used for treatment of C. difficile infections. It is a drug that is focused on anaerobic bacteria. Remember, anaerobic bacteria are those organisms that don't like to have oxygen around in order to grow. So it's focused on that group of bugs. So with that overview of some of our common antibiotics, let's turn and talk about multidrug resistance or antibiotic resistance. MDROs are a group of bacteria with clinically important resistance. Sometimes it's just a single drug resistance that defines an organism of importance to us. For example, methicillin resistance in Staphylococcus aureus is a very important feature of that organism. It affects the drugs we can use to treat it, and it has implications for how challenging it will be to clear infections. Vancomycin resistance in Enterococcus species is another example of a single drug bug combination. With the gram-negative organisms, we tend to see accumulation of resistance to multiple classes of antibiotics. And it's because a lot of these resistance elements travel together. So one bacteria can acquire resistance quickly to many classes. And we see this in the whole family of Enterobacteriaceae, but also Pseudomonas and Acinetobacter. So this table sort of outlines some of the common abbreviations and key antibiotic resistance patterns in healthcare-related bacteria. So MRSA, methicillin resistance, and Staphylococcus aureus is pretty familiar to all of us, as is probably VRE or vancomycin resistance in Enterococcus. When you look at the gram-negatives, you see ESBLs, which stands for extended spectrum beta-lactamase. And remember, the beta-lactams were those penicillins and cephalosporins, and that's where you see resistance with ESBLs. And that's frequently seen in the Enterobacteriaceae family. Carbapenem-resistance, or CRE, in Enterobacteriaceae as well. And with Pseudomonas and Acinetobacter, we often call them just multiply drug resistant because it's acquisition of resistance to several classes that help us define resistance in those bacteria. So I'm just going to stop for a second and check and make sure there aren't any questions that have come up so far in the chat. Hopefully everyone's pretty comfortable with that overview of bacteria and antibiotics. So now we're going to shift into the resistance part of this discussion. There are a lot of different ways that bacteria can become resistant to antibiotics. Here outlined in this cartoon as well as on the side are some of those examples. So bacteria can produce proteins. Generally, they're enzymes that destroy antibiotics. And the way you can figure out which antibiotic class is at risk is by looking to see how the enzyme is named. So beta-lactamase is an enzyme that chews up beta-lactams. Cephalosporinase is an enzyme that chews up cephalosporins. And carbapenemase is an enzyme that chews up carbapenems. And that's helpful as we're trying to think about which enzyme are we dealing with. One thing to note, carbapenemase enzyme can chew up not just the carbapenems, but also the cephalosporins and the other penicillins. So these enzymes are named perhaps against the broadest or the biggest drug that they attack, but they can actually have activity against some of the other classes that are related in structure. And so that's why you see the beta-lactamases and cephalosporinases kind of combined. Now, another way that bacteria can become resistant is through changes in their cellular structure. Those changes can either block the binding site of the antibiotic, or it can just disrupt the function of the antibiotic. And an example of that is there is a change in one of the normal proteins related to synthesizing DNA and RNA in bacteria that, if it's altered, drives resistance to the fluoroquinolones. So changes in the protein's structure reduces the effectiveness of that class of drugs. And then the last thing that bacteria can do is to reduce their exposure to antibiotics, either by pumping the antibiotics out of their cellular space, or by creating barriers in their cell wall and cell membrane so that the drugs can't get in. For example, there's a protein that sits in the cell wall of a lot of bacteria called the porin protein. And that porin channel is a way that antibiotics can enter into the cells to then take action. But mutations or changes in the structure of the porin proteins can block access to antibiotics to get into the cell. So I want to kind of describe a couple of cases and show you how they highlight examples of resistance. This first one is a 70-year-old who was admitted from the hospital to a nursing home. Prior to admission, they were treated for a catheter-associated urinary tract infection with ceftriaxone for about a week. And at the time of transfer, the urinary catheter was still in place. There was a repeat urine culture ordered by a physician prior to removing catheter. Sometimes that happens, although we wouldn't encourage that practice if the person didn't have signs or symptoms. But in this case, the culture grew something. And hopefully, none of you are surprised to hear that the culture grew something, because we know that when there's an indwelling urinary catheter in somebody's bladder, it makes it very easy for bacteria to stick and stay in the urinary tract. And what you see on the right-hand side of the slide is the susceptibility report that came from the lab along with this E. coli. So a lot of resistance. So when you look at the drugs that it has resistance to, they are things like ampicillin, cefazolin, encefapine, ceftriaxone, so the beta-lactams, right? The penicillins and the cephalosporins. Unfortunately, it's also resistant to levaquin and trimethoprim sulfoxazole or Bactrim. So it has susceptibility, though, to the aminoglycosides, that's gentamicin and tobramycin, and to one of the carbapenems, meropenem. So if I were standing in front of all of you, I might ask somebody what type of resistance they think this might reflect. If anybody wants to chat that in, I'll give you a second. Take a guess if you'd like. But since I'm not seeing anything come through right away, I'm going to go ahead and tell you this is an ESBL. So this is, or an extended spectrum beta-lactamase. And this is the enzyme that causes a lot of penicillin and cephalosporin resistance in gram-negatives. When we look at the resistance patterns like the one we just saw, there are sort of two ways that organisms can have that resistance phenotype or those patterns. One is because they have what's called innate resistance, meaning the resistance genes are already a part of their bacterial DNA, already in their chromosomes. And one of the types of resistance genes that can sometimes be a part of bacterial chromosomes is something called AMP-C. It's just a specific gene that confers resistance to the penicillins and cephalosporins. So the bacteria, from the start, already has the ability to be resistant to these classes of drugs. What happens in clinical world is that the resistance becomes uncovered as this gene, AMP-C, gets overexpressed by the organism. So there are certain bacteria like Serratia and Pseudomonas and Acinetobacter that may have this innate resistance to the penicillins and cephalosporins. Now, the other way that a bacteria can become resistant like this is through acquisition. In this case, the resistance genes enter the bacteria through mobile genetic elements. So it's not a part of their original makeup, chromosomal makeup. It's something they get after from being in the environment or being able to pick it up from exchange with another bacteria. These mobile genetic elements are called plasmids, and that's how the extended spectrum beta-lactamases can be shared among bacteria. And we usually see this more frequently in organisms like E. coli and Klebsiella. But these days, we see both the innate and the acquired resistance to cephalosporins expressed in gram-negative. So here's another case. It's another 70-year-old admitted from the hospital to a nursing home, had a more complex history, including surgery, being in the ICU, and at one time being on a ventilator. At the time of transfer, he has a tracheostomy still, a PEG tube, a urinary catheter, and a large cecal pressure ulcer. The physician sends culture from the tracheostomy secretions, and it glows Klebsiella pneumonia, very high amount. And now take a look at the resistance patterns reported from the lab for this bug. It's pretty grim, right? Almost entirely resistant. One drug, amikacin, which is an aminoglycoside, is said to be intermediately susceptible. This pattern is frequently what we see when an organism has a carbapenemase or a carbapenem-resistance phenotype. So carbapenem-resistance in the gram-negatives are very terrifying because, as you can tell, we just don't have almost any drugs available to treat those infections. These drugs, as I mentioned before, are the really broad-spectrum agents, and they're reserved for very severe, complicated infections with multiple bacteria because they have such a broad spectrum of activity, and they do cover some of our resistant bacteria as well, like the ESBLs. However, when you see carbapenem resistance, you have markedly reduced options for treating these infections. And we don't have very many agents, if any, in the pipeline for managing these serious gram-negative infections. One of the biggest concerns about the carbapenem resistance mechanism is that, like the ESBLs, you can see carbapenemases found on those same mobile genetic elements or plasmids, which enable the resistance to be spread. So there are a couple of different ways that gram-negative bacteria can become resistant to the carbapenems. Sometimes the bacteria have to make several changes in a sequence almost in order to become resistant. So they have to either have or acquire a cephalosporinase, which is to break down those cephalosporins and beta-lactams. Then they have to lose one of the proteins in their cell wall, the porin protein that we talked about earlier, so that the carbapenem agent can't actually get into the cell. And they have to gain a pump to push additionally any drug that does manage to get into the cell out. So there's a lot of steps along the way for these bugs to become carbapenem resistant. Now, an easier mechanism is for them to acquire the resistance through a plasmid, which carries the genes for the carbapenem resistance, and those are, again, called carbapenemases. And examples of those genes include KPC, which stands for Klebsiella pneumoniae carbapenemase, because it was a Klebsiella that the resistance enzyme was first isolated from. NDM, Vim, OXA48. These are just examples of the genes that relate to carbapenem resistance. So why are we talking about carbapenemases a little bit more specifically and in detail? Well, it's because of this highly mobile characteristic of them. These elements and this resistance can be shared very quickly between different bacteria. And it's the same way that we saw ESBL spread, cephalosporin resistance, many years ago. There are a couple of carbapenemases that are getting a lot of attention here in the U.S. I mentioned KPC, the Klebsiella pneumoniae carbapenemase, and then NDM, which stands for New Delhi metallo-beta-lactamase. That is, when that resistance was first described, a lot of the people had traveled abroad and come back with infections, and they found that NDM was the specific gene that led to the highly antibiotic-resistant infections they had. Nowadays, we're seeing people without any travel history developing infections with NDM1, which tells us that it's become part of the healthcare environment in some communities. And that's scary. The important opportunity for us is to identify and contain these bacteria which produce these carbapenemases in order to prevent the spread of this resistance to other people and to other bacteria. So in the last few minutes, I'm going to shift gears to just talk a little bit about the lab and how the lab can help us identify resistant organisms. But before I jump into that, it's helpful to maybe remind ourselves of some of the strategies that our labs use to tell us what bacteria are causing infections. And having a little bit of background about these strategies helps us to interpret the information that the lab will send us. So let's start with how the lab identifies bacteria. There are a couple of different ways that can be done. The first is probably the most common activity happening in most microbiology labs, which is growing the bacteria. So you submit a urine specimen for culture, and the laboratory personnel will plate a sample of that specimen directly onto culture plates, and they'll incubate them. And when bacteria start to grow, the system will flag, or the technicians will notice that there's now organisms growing on the plate. And then they will do things like the gram stain and some other biochemical reactions to say what exactly is that bacterial isolate growing on those plates. So that's the sort of traditional culture method. There are ways to streamline that process through use of selective culture media. An example of that is chromager, and you see a picture of a chromager plate in the slide to the right. And what you see there is that there are different colors of growth. And the way these culture medias work is they are designed to react with certain features of the bacteria so that one organism grows up pink on the plate, another organism grows up green or yellow, and it's a faster way to visually identify what's growing. Now, a different technology and something that is gaining a lot of use in the lab is examining pieces of the bacteria in order to identify what it is. There are molecular diagnostic tests which take fragments of the DNA or RNA of bacteria, and based on those fragments can identify what the organisms are. This technology is called nucleic acid amplification, or sometimes it's referred to a specific amplification method, polymerase chain reaction, or PCR. And you may have heard of that for some of the tests that you send off to the lab. A very new technology, which is using kind of weight and the charge of ions in the organism, is a very fast way to identify organisms, but it's a very expensive system, and so a lot of labs, clinical labs, don't necessarily have this in place yet. So that's how they identify the bugs. But the other piece then is knowing what the susceptibility patterns are for these organisms. And in order to do that, you have to test the growth of these organisms in the presence of different antibiotics, and that's how they determine which antibiotics inhibit growth and which antibiotics don't inhibit. And they define the susceptibility using something called the minimum inhibitory concentration. And that's the lowest amount of the drug needed to stop growth of the bacteria. So you see a couple of different examples of how a minimum inhibitory concentration can be defined in the lab. The gold standard is something called broth microdilution, and what you see there is a plate with lots of wells, and each well has a slightly different concentration of drug. And so when you inoculate those wells with the same amount of bacteria, you can see places where the wells are clear, the concentration of drug inhibited growth. But when you start to see places and the wells are cloudy, it tells you that that's the concentration that the bacteria are able to overcome and grow despite the presence of the drug. So it's a way to very accurately define that minimum inhibitory concentration. There are some other methodologies that you see described, like disc diffusion. Those discs each have antibiotic impregnated within the disc, so when you drop it down, the concentration closest to the disc is the highest concentration of drug, and then the drug moves out from there. So the size of the cleared zone around the disc gives you a sense of how well the antibiotic is able to inhibit growth versus not. And on that plate, you can see some of those discs don't really inhibit growth at all, and you can see that bacteria grow all the way up to the edge of the disc. And in some of those discs, you see a very large zone of clearance. That's how those work. And just like identifying bacteria using molecular tests, we can also identify specific resistance genes using the same molecular technology we talked about before. So that's susceptibility. And the last thing to mention is that a lot of our labs use systems that are automated to help speed up and streamline the process for identification and susceptibility testing. And these automated systems can combine the growth and susceptibility into one platform, which means you get the answers much, much quicker. They use growth panels, kind of like the broth microdilution panels you saw before. Some of them have biochemicals to identify the organism, and others have concentrations of antibiotics to do the susceptibility testing piece. And a computer will identify the organism and interpret the susceptibility using algorithms that are predefined in the system based on the growth patterns of the bacteria on the panel. And at the bottom, you see some examples of automated systems that we see in clinical labs. So with that sort of background about microbiology testing, here's the question. How well do our laboratories identify the presence of carbapenemases, that very specific form of carbapenem-resistance among these gram-negative bacteria? Well, there are different ways that labs can look for the susceptibility to carbapenems, either using manual or automated testing. And I guess what's important for us to recognize is that there are some challenges in how consistently and accurately laboratories can identify carbapenem resistance based on which carbapenem they're using and what technology or system they're using as well. For example, sometimes low levels of carbapenem resistance may not be detected by the automated testing platforms. In other situations, you may know that an organism has carbapenem resistance, but you may not know if the bacteria has that resistance because of a carbapenemase or because it acquired that series of changes that confer resistance but isn't as easily shared to other bugs. So, the lab does have options for confirming carbapenemase production, but it does take some additional testing and additional resources to be available in the lab. Here are just two strategies that labs can use to confirm carbapenemase production. The first is called a modified Hodge test, and you see a picture of a negative and a positive on the plate next to this text. Basically, what you're looking at is a plate that's got a whole lawn of susceptible E. coli plated out. And in the center of the plate, they dropped a carbapenem disc. And what the streaks are, the three sort of spokes going toward the disc, are negative controls, meaning this organism does not produce a carbapenemase, a positive control, which is an organism that is known to produce a carbapenemase, and then the third streak is the isolate that you are studying. So interpreting a modified Hodge test takes some skill because you have to look at the zone of clearance where the streak of organism being tested intersects with the lawn of the E. coli. And when you look at the negative control, you see a very clean, clear zone of inhibition. All the way along that streak, the E. coli is kind of blown out by the carbapenem. Compare it to the way the E. coli is growing along the positive control streak. If you can see, it looks like there's a pinch to the zone. And what's happened is the carbapenemase being produced by that positive control isolate is leaching out into the area of the plate, inhibiting the carbapenem disc and allowing the E. coli to grow closer in than it ordinarily would. So hopefully that's easy for you to see. I just saw a note in the chat box that someone doesn't have sound. So I'm going to stop and check and make sure that...
I'm hearing you okay.
Okay, great. Thank you. I just want to make sure.
Yeah.
Thanks. Okay, so that is how the modified Hodge test is sort of a growth test to confirm the presence of a carbapenemase. The other way, again, is that molecular detection of resistance. So you can use PCR or nucleic acid amplification tests, specifically testing for the presence of those carbapenemase genes like the KPC, NDM1, and VIM. But putting it all together, here's what some of the takeaways are. Our labs can do a lot to identify resistance very broadly and as well as carbapenem resistance. But if we are wanting our labs to help us detect carbapenemase production, we have to know that it depends on the kind of test that they use and also whether they have the capacity to do some of those additional confirmatory tests to verify that the resistance is truly due to a carbapenemase. And as I said, it sometimes requires additional staffing, time, resources, and technology. So what you all have the opportunity to do is talk to your lab and try to understand their testing methods and understand what they can do to help you determine if there's a carbapenem-resistant organism reported in your facility, what the resistance might be due to. Is it from a carbapenemase, or is it from some other type of resistance mechanism? The reason this is important to understand is that the true burden of carbapenem resistance in your facility might be either over or underestimated depending on the tested methods and the laboratory reporting capacity available to you. I think it starts with a conversation. You can take some of this information back to your laboratory director and say, I'd like to understand a little bit more about how we look at gram-negatives and what we're able to do in terms of understanding carbapenem resistance if we detect it. You can learn a little bit about the type of identification and susceptibility testing that they do, and in particular ask them, how easy would it be for them to flag an organism that shows up in one of their testing centers as a carbapenem-resistant organism? You could find out if they have the capability of doing confirmatory testing for carbapenemase production. And that may or may not be the case, especially if you're working with regional or commercial referral labs. But I think one of the most important opportunities is to try to discuss a strategy with your lab for notifying your facility if a carbapenem-resistant bacteria becomes identified, because that is so critically important in terms of your clinical management of residents as well as your infection prevention program. Another thing that your laboratory can do is provide you with sort of a summary snapshot of antibiotic resistance patterns across all of the organisms cultured from residents in your building. This is called an antibiogram. And I apologize if on the screen it's a little bit hard for you to see. But an antibiogram basically is a summary of the bugs that are frequently identified in culture and the percent susceptibility to some of the common antibiotics that are used to treat those infections. So you see kind of blown up is one row of an antibiogram. On the far side, you see E. coli, and then as you look along the top columns, those are all different antibiotics and the percent of those E. coli isolates that were susceptible to each of those different drugs. So it's a yearly summary, and it allows you to trend resistance patterns over time. So that is something, a tool perhaps that you could talk to your laboratory about as well. So just as a summary slide, antibiotic resistance is a growing issue across all healthcare settings, and carbapenem resistance in particular is a very scary threat to all of us because it really is driving infections which we are no longer able to treat with the available antibiotics. At a high level, understanding the common organisms causing infections in the residents you care for and knowing the most frequently prescribed antibiotics in your facility are important pieces of the equation to understand antibiotic resistance that may be present in your facility. And the laboratory is really a tremendous partner and resource for you in identifying and communicating when resistant organisms are detected. So I'm going to stop there. I think there are just a few minutes left and hopefully some questions out there from all of you in the audience. But I want to just thank you again for your time and the opportunity to talk with you and open it up to any questions.
Thank you very much, Dr. Stone. This is Christy again. But before we go to questions, I think it's helpful in your state's efforts to support antibiotic stewardship in your nursing homes. So, Dr. Stone, do you mind going to the next slide?
Absolutely. Here we go.
So, All right. Well, on the handouts, I'm not seeing it on this slide.
Sorry, let me see if I may have handed over the control.
Oh, did you hand it to me?
I handed it to our host. Sorry, Christy, that was my fault.
Hand it to me.
Let me try.
Anyway, while you're doing that, sort of the Antimicrobial Stewardship Program Toolkit for long-term care that I want to make sure that everybody is aware of. And in that toolkit, there's some recommended nursing-driven core elements that are important. It's a great resource. So that's in your handout. There's also there's also some for Michigan and Wisconsin as well. So these are resources that have been put together, primarily by the health departments in those states. So I want to make you aware of that. At the very last slide, there's also resources from the CDC. And all of this, I know this is a complicated topic, and we're just touching on just an introduction at this time, but I wanted you to be aware that there's plenty of other resources to help you in your efforts to really get a good antibiotic stewardship program going. On the last slide, too, there's contact information if you need any more information from each of the states. So are there any questions? And operator, could you please remind us how to get in queue for questions?
Certainly. The floor is open for questions. If you do have a question, please press the number 7 or the letter Q on your telephone keypad. Questions will be taken in the order they were received, and if at any point your question has been answered, you may press 7 or Q again to disable your request.
And while there's questions, hopefully, that will come in queue, I just want to ask, Medora, I know there's 2 more webinars in this series that will be held early next year. Do you just want to touch a little bit on what we're going to talk about in those sessions?
Yeah, so the next 2 webinars are going to sort of come off of this one. We're going to talk about CRE prevention in long-term care facilities for our next one. And both of these will be next year, so in the next coming months we'll have a little bit more information about those. But the third one will also be focused on C. diff and C. diff prevention in long-term care facilities.
Thank you, Medora. Operator, is there anyone in queue?
We have not had any questions as of yet.
Okay. So I see there's a question about the handouts. You should have all received a link to the handouts. They are available on the LSQIN website. I was just trying to quick get that link. It's not really coming up right now. I'm sorry. So, Dr. Stone, is there anything else you want to share?
No, just to say thank you. I hope this was content that was useful, and I would welcome people to send me comments or questions through my email or through Stratus or Medora there at the health department, so we can make sure that you all feel comfortable with this information. But it's really a pleasure to chat with you today, and I look forward to speaking with you again in the new year.
And I know that this is a very hot topic right now, so you'll be hearing more and more about the use of antibiotics in healthcare-acquired conditions for those of you participating in the National Nursing Home Quality Care Collaborative. So thank you very much again, Dr. Stone, for speaking with us today. We really appreciate that you were able to talk with us. And Medora, thanks for organizing this webinar. All of you that have attended, you will receive a link to a short evaluation via email after the webinar, and please take a minute to provide feedback on this session. Once you've completed the evaluation, you will receive a certificate of completion. And make sure that everyone on your team that's participated in this webinar receives the certificate. This session was recorded, and you will note that in chat that I have put the link of where the recording will be available in about 2 weeks, and that's on the LSQIN website. Dr. Stone, there's a question here. Do most labs do the data collection, or do we need to ask for them?
So thanks. Most labs have these data available. in terms of developing, for example, a facility antibiogram, they should already have the information necessary. You might have to talk with them or request that they do a summary report for you and create the antibiograms. They may not automatically make those available, but they should be able to do it on request. The only other thing to sort of know about the antibiogram is that oftentimes you need to have at least a minimum number of isolates from a particular species of bacteria in order to have accurate information about the susceptibility. So if your facility doesn't generate enough data in a year, it would be possible to look at like a 2-year window to have enough numbers of isolates to make your antibiogram reliable. And so the laboratory should be aware of there are some standards for developing antibiograms that they should be aware of. It's a great question.
Thank you. All right. I think that's it. Our time, we're at the top of the hour, so thank you all for joining us, and thanks again, Dr. Stone and Medora. You all have a great afternoon.
Thanks. Take care.
This concludes the webinar.
Thank you. This does conclude today's teleconference. We thank you for your participation, and you may disconnect your line at this time.